The use of familiar musical notation can offer a unique clarity and precision to the study of arrhythmias and can enhance students' ability to subsequently interpret electrocardiograms. Unlike the sound of opening and closing of stenotic and regurgitant valves, arrhythmias do not intrinsically produce sound. However, the richness of the information in cardiac arrhythmias can in fact be specified in musical notation and conveyed by sound. In this piece, I will provide a systematic overview of all common arrhythmias. In the proposed system, atrial or supraventricular activity is denoted on the top staff, and ventricular activity is denoted on the bottom staff, reflecting the anatomic position of the atria and ventricles relative to each other. The atrium is instrumented by chimes, while the ventricle is instrumented by a snare drum, to allow the listener to easily distinguish the site of electrical activity by timbre of instrumentation. The P wave is represented as an atrial 32nd note just prior to a ventricular 8th note, the QRS complex, occurring on the beat. A 32nd note was chosen to approximate the physiologic PR interval of 120 to 200 milliseconds. The tempo corresponds to the ventricular beats rather than the atrial beats because the ventricular beats determine cardiac output and represent the heart rate measured by most devices in medicine. To reflect the physiologic heart rate range of 60 to 100, the default tempo is set at 80 beats per minute, or BPM, which happens to be the unit for tempo in both music and cardiology. Let's take a listen to normal sinus rhythm. In this module, we will go over atrioventricular blocks, sinus node dysfunction, regular narrow complex tachycardias, irregular narrow complex tachycardias, premature contractions, and end with wide complex tachycardias. Let's start with the atrioventricular blocks. Atrioventricular blocks, which are categorized into first, second, and third degree blocks, can be neatly illustrated via musical notation. In first degree atrioventricular block, the atrial 32nd note is prolonged to a 16th note, reflecting the prolonged PR duration to more than 200 milliseconds. Let's take a listen to first degree AV block. In second degree AV block type 1, Winky Bach, the progressively offbeat ventricular eighth notes denote progressive PR prolongation until a ventricular eighth note is dropped, after which the PR interval is shortened again. Let's take a listen to the second degree AV block type 1, Winky Bach. In second degree AV block type 2, a ventricular eighth note is dropped, but the PR interval remains constant. Let's take a listen to second degree AV block type 2. In 2-to-1 AV block, a ventricular eighth note is dropped every 2 cardiac cycles, leaving an unmatched atrial 32nd note every 2 beats. Exercise, which causes withdrawal of vagal tone and increased sympathetic tone, can help differentiate whether 2-to-1 AV block is due to Mobitz type 1 or 2 AV block. If the atrioventricular block is Mobitz type 1, then increased sympathetic tone would facilitate conduction through the AV node and may lead to resolution of the AV block. If the baseline atrioventricular block is infranodal, Mobitz type 2, the atrioventricular block will not resolve and will likely worsen as the sinus rate increases. Let's take a listen to 2-to-1 AV block. In third-degree AV block or complete heart block, there is no interchamber communication. However, the intervals between the atrial 30-second notes, reflecting the P to P intervals, remain constant, and the intervals between the ventricular eighth notes, reflecting the R to R intervals, remain constant as well. When the sinoatrial note is not available to suppress the activity of subsidiary pacemakers, junctional and ventricular escape rhythms can occur. The inherent rate of these backup pacing cells decreases along the pathway of the conducting system. Ventricular eighth notes occurring at 40 to 60 beats per minute suggests a junctional focus. Let's take a listen to complete heart block with a junctional focus. Meanwhile, ventricular eighth notes occurring at 20 to 40 beats per minute suggest a ventricular focus. Let's take a listen to complete heart block with a ventricular focus. Now that we've covered atrioventricular blocks, let's move on to sinus node dysfunction. Sinus node dysfunction can result from failure of P cells to produce an impulse, leading to sinus pauses and sinus arrest, or failure of the T cells to transmit the impulse, leading to sinoatrial exit block. In simple sinus bradycardia, the tempo is decreased below 60 beats per minute, but the relationship between the atrial 30-second and ventricular eighth notes remains preserved. Let's take a listen to sinus bradycardia. Sinoatrial arrest is when the sinoatrial node does not discharge an impulse for at least 2 seconds. Let's take a listen to sinoatrial arrest. Sinoatrial pause is when the sinoatrial node does not discharge an impulse for less than 2 seconds. At a heart rate of 60 beats per minute, each beat represents 1 second, so a rest of 2 beats corresponds to absence of sinoatrial impulse for 2 seconds. Note that the resumption of the atrial eighth note occurs off-cycle. The P to P interval of the pause or rest is usually not a multiple of the preceding normal P to P interval. Let's take a listen to sinoatrial pause. If the P to P interval of the pause or rest is a multiple of the preceding normal P to P interval, that suggests the presence of a second-degree sinoatrial block, type 2. In second-degree sinoatrial block, type 2, the sinoatrial impulses are blocked sporadically, with no prolongation of the duration of time from the discharge of the impulse in the sinoatrial node to the time of the atrial depolarization. Therefore, the pause resulting from the blocked sinus impulse will be wrapped within a P to P interval that is an exact whole number multiple of the normal P to P interval. First degree and third degree sinoatrial block are not routinely discerned from surface ECG, so they are not included here. Let's take a listen to second degree sinoatrial block type 2. Needless to say, asystole consists of no notes in the atrial or ventricular staff. Now let's move on to regular narrow complex tachycardias. Narrow complex tachycardias can be divided into those that are regular and those that are irregular. Regular narrow complex tachycardias include sinus tachycardia, ectopic atrial tachycardia, AVRT, and AVNRT. In sinus tachycardia, the tempo is increased above 100 beats per minute, but the relationship between the atrial 30-second and ventricular eighth notes remains preserved. Let's take a listen to sinus tachycardia. In ectopic atrial tachycardia, there is a single abnormal pacemaker site in the atrium outside of the sinoatrial node, producing P waves that are of consistently abnormal morphology and of consistently abnormal PR intervals. Hence, ectopic atrial tachycardia is illustrated with atrial 30-second notes spaced consistently earlier than expected, reflecting the consistently increased PR interval. Let's take a listen to ectopic atrial tachycardia. Short RP supraventricular tachycardias include typical AV-NRT, which is the most common one, and orthodromic AVRT. Atrioventricular reentrant tachycardia is triggered by an early atrial 30-second note, a premature atrial contraction, followed by a fast regular ventricular eighth note series that can cause retrograde P waves. Let's take a listen to atrioventricular reentrant tachycardia from a premature atrial contraction. Atrioventricular nodal reentrant tachycardia, AV-NRT, is triggered by an early atrial 64th note, PAC, followed by fast regular ventricular eighth notes that can cause retrograde P waves. AV-NRT and AVRT are both short RP SVTs, but AV-NRT is the shortest among the two. AV-NRT's short RP interval is typically less than 70 milliseconds, whereas AVRT's short RP interval is typically more than 70 milliseconds. For this reason, the interval between the ventricular beat and the retrograde atrial beat is represented by a 64th note in AV-NRT and a 30-second note in AVRT. Let's take a listen to atrioventricular nodal reentrant tachycardia from a premature atrial contraction. In fact, the brevity of the RP interval in AV-NRT is such that the P wave may distort the initial portion of the QRS complex, mimicking a Q wave in the inferior leads, lie within the QRS complex, thus being invisible on surface ECG, or distort the terminal portion of the QRS, mimicking an S wave in the inferior leads, or causing an R' in V1. Thus, an alternate version of AV-NRT demonstrating A on V tachycardia is included, where the P and QRS are simultaneous. Let's take a listen to AV-NRT with A on V phenomenon. The means of initiation can also offer insights for differentiating AVRT and AV-NRT. AVRT can initiate on a PAC, but does not require PR prolongation. In contrast, typical AV-NRT requires initiation on a PAC with a prolonged PR at the start of the run of tachycardia. This implies that it was blocked in the fast pathway and is conducting in the slow pathway. For this reason, the atrial 64th note triggering the start of AV-NRT has been placed 1/64th ahead of where it would be expected to reflect the PR prolongation that occurs after the PAC in AV-NRT, but not in AVRT. If it initiates on a PVC instead of a PAC, the rhythm is probably AVRT and sometimes a typical AV-NRT. In AVRT, the PVC can activate the atrium through the accessory pathway and be unable to conduct retrogradely up the AV node. The activated atrium then conducts anterogradely through the AV node to activate the ventricles. Let's take a listen to AVRT that initiates on a premature ventricular beat. Atrial flutter is a regular narrow complex tachycardia characterized by impulses at 250 to 350 beats per minute and a reentrant circuit around the tricuspid valve annulus and through the cavo-tricuspid isthmus. In atrial flutter, there is regularity both to the atrial 32nd notes and the ventricular eighth notes, with the former occurring as a multiple of the latter. Let's take a listen to slow atrial flutter with 2-to-1 conduction. Atrial flutter can be slow or rapid and can involve different ventricular conduction ratios, such as 2-to-1. Let's take a listen to rapid atrial flutter with 2-to-1 conduction. Atrial flutter can also be 3-to-1 or 4-to-1 or other combinations. Let's take a listen to atrial flutter with 3-to-1 conduction. Atrial flutter with variable conduction involves switching between different multiples of conduction ratios, as indicated by the variable nature of the ventricular eighth notes, sometimes after 2 atrial impulses, sometimes after 3. This is in stark contrast to complete heart block, where there is no consistent relationship between the atrial 32nd notes and the ventricular eighth notes. Let's take a listen to atrial flutter with variable conduction. Now that we've covered the regular narrow complex tachycardias, let's move on to the irregular narrow complex tachycardias. Irregular narrow complex tachycardias include atrial fibrillation and multifocal atrial tachycardia. Atrial fibrillation is characterized by chaotic electrical activity in the atria, with up to 300 to 600 atrial impulses per minute, most of which are blocked by the AV node. In atrial fibrillation, the atrial 32nd notes are disorganized, with P waves of varying morphology and varying PR intervals. Atrial fibrillation is characterized by irregular intervals between the ventricular eighth notes, irregular R2R intervals. Let's take a listen to atrial fibrillation without rapid ventricular response. Note that there is not always a clear P wave preceding each ventricular eighth note in atrial fibrillation. Atrial fibrillation with rapid ventricular response refers to the same phenomenon but with a ventricular response rate exceeding 110 beats per minute. Let's take a listen to atrial fibrillation with rapid ventricular response. Unlike the disorganized electrical activity of atrial fibrillation, multifocal atrial tachycardia, or MAT, involves distinct, at least 3 ectopic foci firing in the atria, leading to P waves of varying morphology and varying PR intervals. MAT is thus illustrated with 32nd notes variably spaced from the subsequent ventricular eighth notes. Importantly, although both have irregular R2R intervals, note that MAT is characterized by identifiable atrial 32nd notes before every ventricular eighth note, reflecting the presence of identifiable P waves before every QRS complex, whereas atrial fibrillation does not have identifiable atrial 32nd notes before each ventricular eighth note consistently. A fermata is added to further convey the temporal variation. Let's take a listen to multifocal atrial tachycardia. Sinus arrhythmia is an irregular rhythm, although it is a benign physiologic phenomenon driven by fluctuations in vagal tone during the breathing cycle, with reduced vagal tone during inspiration and increased vagal tone during expiration. Retardando corresponding to decreased rate during expiration and accelerando corresponding to increased rate during inspiration are used to convey the variation in heart rate in sinus arrhythmia. Let's take a listen to sinus arrhythmia. Tachycardia-bradycardia syndrome is denoted by the presence of both high tempo, above 100 beats per minute, and low tempo, below 60 beats per minute rhythms in a single patient. The tachycardia component could be atrial fibrillation, atrial flutter, atrial tachycardia, AVRT, or AVNRT. The bradycardia component could be sinus arrest, sinus pause, sinoatrial exit block, slow atrial fibrillation, or sinus bradycardia. For illustrative purposes, tachycardia, bradycardia syndrome with rapid and slow atrial fibrillation is illustrated here. Let's take a listen to tachybrady syndrome. Now that we have covered the irregular narrow complex tachycardias, let's move on to premature contractions. Premature atrial contractions and premature ventricular contractions are ectopic beats that originate from outside the normal pacemaker cells, causing the atria and ventricles, respectively, to contract prematurely. This is illustrated in the third cardiac cycle of each example. PACs involve an early onset atrial 32nd note with no compensatory pause, such that the next atrial 32nd note also arrives early. Let's take a listen to premature atrial contraction with no compensatory pause. Conversely, a premature ventricular complex involves an early onset ventricular eighth note with a compensatory pause such as the next atrial 32nd note arrives as originally scheduled. Let's take a listen to a premature ventricular contraction with compensatory pause. Now that we've covered premature contractions, let's move on to wide complex tachycardias. Wide complex tachycardia refers to any rhythm with a heart rate more than 100 beats per minute and QRS with more than 120 milliseconds. The most common wide complex tachycardia is ventricular tachycardia. Identification of VT requires evaluation of a number of criteria, including AV dissociation, such as the presence of a fusion beat, P waves marching through, or capture beats. The presence of a fusion beat is denoted with an accent mark, which reflects the larger amplitude QRS complex that occurs when a supraventricular and ventricular impulse coincide at the same time. Two versions of VT are presented: a monomorphic version in which all ventricular eighth notes had the same duration. Let's take a listen to this ventricular tachycardia with fusion beat. And also a polymorphic version, in which the ventricular eighth notes are of varying width, reflecting a continuously changing morphology of the QRS complex from beat to beat. In VT, P waves may be absent, not visible, or occur independently of the QRS complexes because the ventricles are activating independently of the atria. Let's take a listen to polymorphic ventricular tachycardia. Meanwhile, ventricular fibrillation consists of disorganized ventricular notes of varying duration, with no clear QRS complexes. Accordingly, the ventricular staff is filled with completely irregular notes of random duration. P waves are obscured in VFib due to the disorganized electrical activity throughout the ventricles, and hence the atrial 32nd notes are not displayed in the atrial staff. Let's take a listen to ventricular fibrillation. Finally, in pulseless electrical activity, despite the presence of electrical patterns, there is no palpable pulse because the contractions are not efficient or are too weak to generate sufficient cardiac output to maintain circulation. For this reason, mute notation is placed on both staves, such that the notes are played with no sound output, corresponding to the lack of cardiac output. The tempo is missing because no number can be detected for the heart rate of pulseless electrical activity. Classical music notation reflects 10 centuries of refinement, driven by the need to accurately preserve and communicate the nuances of music across countries. The development of the staff occurred in the 11th century, occurring for the accurate representation of pitch. The medieval, Renaissance, Baroque, Classical, and Romantic periods saw the invention of mensural notation to indicate the relative durations of notes, the creation of time signatures and rhythmic modes, the standardization of expressions for tempo and dynamics, and the development of comprehensive articulation markings. In this 21st century, musical notation provides a framework very well developed for describing cardiac arrhythmias with a precision that may not be as efficiently achieved with just words alone. This framework allows musically trained students to understand arrhythmias in highly specific terms, and additionally allows non-musically trained students to hear arrhythmias. Use of this nomenclature, which has been systematically refined by thousands of composers over centuries, has untapped potential for describing arrhythmias in medical education and should be further explored and encouraged. Thank you.